My name is Austin Kulasekraj. I'm a consultant hematologist and honorary clinical lecturer based at King's College Hospital and King's College London in London, UK. Thank you for the organizing committee for asking me to do this session as a Meet the Expert. It would have been fantastic if we had been able to meet face-to-face, but hopefully you're going to enjoy the whole symposium and able to take some take-home messages from this session. So I probably have tasked myself with a difficult option of trying to put together all these diseases in the context, predominantly aplastic anemia in the context of MDS, and also other diseases like paroxysmal nocturnal hemoglobinuria, T large granular lymphocytosis leukemia, and pure red cell aplasia. And what I'll try to do in the next 40 minutes or so is try to give you some published data, some newer data to how to help to delineate, and more importantly, as a clinician, more importantly, to how to manage them and how to treat them. So these are my disclosures. So what I'm hoping as a learning objective from this session is, can we be able to distinguish MDS from other pure autoimmune conditions like pure red cell aplasia, LGL, PNH, and aplastic anemia? Can we understand what is the role of somatic gene mutations in aplastic anemia, MDS, and also inherited bone marrow failure syndromes? And can we make therapeutic decisions based upon the understanding of the pathophysiology of the disease? And more importantly, do biomarkers of the disease help us to make these decisions? So I'm just going to take you through this patient's case, and I'd be extremely grateful if there are participants in this session, if you could start voting when the voting questions come, because I want to keep it more interactive. I want to leave loads of time towards the end of the session so that we can keep asking, because this is technically going to be a lecture, but it's not supposed to be because it's a Meet the Expert. But since in a virtual world, we might not be able to do that properly. So this is a gentleman who presents with new onset pancytopenia. So significant pancytopenia with neutrophils of 900 and 9.9 platelets of 25. He's red cell transfusion dependent. He does have a PNH clone of 12% granulocytes, 23% monocytes, and a small red cell clone. His bone marrow is hypocellular, does not have any excess of bloods. He does have some megakaryocytic atypia and also dyserythropoiesis with no fibrosis. He's got a normal karyotype. We've also done a FISH for 5q7 and also trisomy 8, and this was negative, and he also has a normal SNP karyotyping. And this was at a time back in 2012, we were just fiddling around with trying to do genetic panels in this context of these pancytopenia as well. And he was found to have a ASXL1 mutation with a VAF of around 15% and a normal telomere length. So I think the question for the audience, if you can start polling, Miguel, if you could set up the polling, is what is the diagnosis? So does this gentleman have AA-PNH? Does this gentleman have MDS-PNH? Or is this a clonal hemoptysis? Or does he have an AA-MDS overlap disorder? So if you don't mind clicking on any of the options which you think is appropriate, that would be fantastic, so that we can keep discussing this case forward. So I think if we could move on, if you show us the results, if that's okay. So this is a gentleman who, so that's fantastic. Thank you so much. So this is more likely so a third of people thought APNH, third thought MDS-PNH, some people thought CHIP, and not overlap disorder. So essentially, this is a gentleman who has presented with this pancytopenia. And what is aplastic anemia? Simplistically, aplastic anemia is you have stem cells with hemopoiesis giving rise to the blood counts, but you have an immunological attack on these stem cells, leading on to marrow aplasia and contraction of the stem cell pool. And this has been elegantly shown by a number of works many years back using confocal microscopy, looking at fat cells compared to CML with loads of cells as well. So what is the pathogenesis of aplastic anemia? And we all know this is an immunologically mediated disease where the hemopoietic stem cells is the target of the immune dysregulation, and cytotoxic T cells are aberrant, and they target the hemopoietic stem cell and lead on to apoptosis of the stem cell and bone marrow failure. But we've had a significant interest in CD4 T cell population, and we were able to demonstrate, number of groups have been able to demonstrate this is due to Th1, Th17, but our focus has been predominantly looking at the T regulatory cells, and we found that the number and the function of the T regulatory cells were aberrant. And not only that, with deep molecular phenotype or deep immunophenotyping or CyTOF, which is time of flight based cytometry using heavy metals, we were also able to identify a particular type of immune signature at the outset for aplastic anemia based on the T regulatory subsets, which leads on to prediction of response to this. And in King's, we tend to go through a comprehensive panel of tests for ascertaining somebody who presents with pancytopenia. Not only do we do the bone marrow, but we also do additional genomic analysis, including SNP karyotyping and myeloid gene panel. And we will also do, in the right context, constitutional gene panels as well. And to rule out Diamond-Blackfan anemia, we test for red cell ADA levels. And we recently started doing ADA2 levels in the right context, to diagnose diseases like DADA2 or CECR1 mutation. But essentially, because as we all know, aplastic anemia is a diagnosis of exclusion. It is important to make sure we exclude other diagnostics, other conditions before you can confirm that this patient has got aplastic anemia. And it's important to have a family tree as well. So there is a big relationship between aplastic anemia and PNH, and it's not a single static state, because these patients can move from one state to the other state depending upon the degree of cytopenia and the degree of hemolysis, and also the PNH clone. A couple of points as well. In patients who have aplastic anemia with a moderate or a large PNH clone, it's quite common to see dyserythropoiesis and also dysmegakaryopoiesis as has been reported before as well. And we all know that cytogenetic clones in aplastic anemia are quite common because they evade the immune attack, like trisomy 8, copy-neutral loss of heterozygosity of 6p, and also deletion of 13q, which is being shown more specifically related to immune-mediated bone marrow failures rather than to myelodysplastic syndrome or other clonal myeloid diseases. And when we first looked for the mutational profile of aplastic anemia, we were able to identify that in approximately 20%, 18 to 20% of patients with aplastic anemia, we were able to identify genomic abnormalities in genes like DNMT3A, ASXL, and also BCOR, BCOR-L1, and PIGA. And these were predominantly low-level BAF, and this was subsequently confirmed by a larger series from NIH Japan and the Cleveland Clinic. So contextually, we were wondering at that stage, what does that mean? Does mutations in the context of aplastic anemia, does that indicate that there is an increased risk of transformation to myeloid malignancy over a period of time with acquisition of genomic abnormalities in the proliferating stem cells? But the recent data which I'll explain in the next few slides, might indicate slightly otherwise. And at that time, interestingly, age-related clonal hemopoiesis was not described. When we published our first data back in 2014, age-related clonal hemopoiesis was never a context, and nowadays you cannot totally escape from that context at all because you need to be aware of this. Additionally, this is something extremely important for clinicians and people using genetic panels at the time of diagnosis in routine laboratories, routine sequencing laboratories, clinical sequencing panels and laboratories. The reason for saying that is predominantly or most exclusively, these mutations at the time of diagnosis are always less than 10% variant allele frequency, or the cutoff less than 10%. So it's extremely rare to find patients at diagnosis having 20-30% mutant allele burden or allele frequency, but technically sometimes it can increase over a period of time as well. And this was also, we were able to show this in our series as well. So, and also in the upcoming RACE data as well, we found that the median allele frequency for the mutations at the time of diagnosis was extremely low and definitely less than the 1% cutoff. So it is important, couple of things. One, these mutant clones are present even at low levels at the point of diagnosis. Immunosuppressive therapy does not necessarily induce new mutations. It leads possibly to expansion of some of the mutant clones. And none of these mutations were predominantly more than the 10% value. So to sum it up, clonal hemopoiesis and acquired aplastic anemia, we all know that hemopoietic stem cells are less or they shrink, and some of the factors indicated there we cannot change, but seemed it possible that due to the proliferative pressure of too few stem cells, these can acquire genomic abnormality secondary to the depleted stem cell pool, and also in the context of an autoreactive immune response, which is happening as a background, and subsequently the treatments we give might sometimes potentiate this, leading on to possibly sometimes expansion of the existing clones and also possibly sometimes acquisition of new clones. And this can lead on to oligoclonal hemopoiesis with increase in the blood counts at that stage, leading on to either abnormalities associated with good prognosis or poor prognosis, or sometimes even intermediate or neutral or fluctuant clones, and predominantly the ASXL1 and DNMT3A clones as well. And that can lead on to either immune-mediated surveillance or genomic instability as well. And we all know that there are a number of routes to clonal hemopoiesis, both in the different contexts as well, both in elderly individuals and also in transplant and also in leukemia as well. So to sum up, clonal hemopoiesis is extremely common in aplastic anemia. I would say it is the rule rather than the exception. And these could be cytogenetic abnormality, loss of heterozygosities of 6p picked up by SNP karyotyping, somatic mutations, and presence of PNH clones by flow cytometry. So what happened to our patient? So this was a patient we talked about. So he had a moderate PNH clone, non-severe aplastic anemia as per the neutrophil criteria because it's more than 0.6, and he did not have any evidence of hemolysis or thrombosis, and we talked about the significance of the ASXL1 clone. So the question is, what would you do for this patient? So he's again, you can start polling if you wish. So this is somebody who's needing blood transfusion, but has also got a moderate PNH clone. And how would you treat this patient? So you can start polling if you wish. So would you offer them a transplant? He's around 50s. Or would you think he should be treated with HOS-ATG and cyclosporin, or a triple regimen with L-trombopag in places where it has got approval? or would you treat with eculizumab or single agent cyclosporin? So if you submit your questions, and we could look at the polls, that would be fantastic to see what people think would be the right option in this context. Can we have the results of the poll, if that's okay? Apologies. Yeah, so despite this patient being non-severe aplastic anemia, I think most people because he's a transfusion-dependent case of aplastic anemia, despite him being non-severe, I would go with a full immunosuppression because it's got a better chance of responding, and that's what nearly 90% of people thought, either HOS-ATG cyclosporin or ATG cyclosporin and L-Trombopag, where there is access, where countries there is access to it as well. So this gentleman, because of the age, as you can see, less than 40, if they do not have a HLA identical donor, then predominantly you would go for HOS-ATG and cyclosporin when L-Trombopag is not yet available upfront, at least in Europe, but I know it's different in US and Canada as well. So, but we've not made significant progress in the immunosuppressive therapy over many years with around 60 to 70% response, but still refractoriness and relapse are major issues, and that is why the first-line treatment with L-Trombopag is being a significant game changer in countries where there is access to the treatment. So then this is based upon preliminary data, nearly 10 years now, showing from the NIH group doing a small phase 2 trial where they predominantly wanted to see whether there will be any utility in the use of L-Trombopag in refractory aplastic anemia. And to their surprise, they found that nearly about 40 to 50% of patients did show response, not only single lineage response, but tri-lineage responses as well, with significant improvement in the cellularity in the bone marrow, which we are never used to seeing in the context of any other treatment. And that subsequently led on to the trial of triple drug therapy with different cohorts. And as you are all aware, it's nearly 4 years old. That led to significant increase in the overall response rate and also complete response rate, nearly reaching up to 6-month CR rate up to 40% and an overall response rate up to 90% compared to the historical cohort. And the cohort 3, where L-Trombopag was given 150 milligram right from day 1 up until 6 months, had the better response. But the question is, will it totally replace transplantation? Is it the new standard of care? And I would say yes, although we are still waiting for the final results of the RACE trial, which is the randomized EBMT trial, which I'll talk to you in a minute. And hence the reason for doing a phase 3 randomized trial for comparing ATG and cyclosporin with ATG cyclosporin and L-Trombopag, and with number of biological studies. And this is the scheme of the patients. This has already been presented by my colleague just before Delatour in the EBMT. So close to 200 patients, equally distributed between the arms because it's a 1:1 randomization. These are the clinical characteristics of the patient. The median age was definitely higher than the NIH cohort, where it was 32, and we had a proportion of older individuals as well, and the cutoff was above 15 years rather than above 2 years, and 2/3 of patients had normal karyotype as well. So this is one of the top line primary endpoints, where you see CR at 3 months being 10% compared to 22% for arm B, with a threefold increase in the odds ratio. And similarly, 70% overall response rate at 6 months compared to 40% in arm A. And this is some of the distribution of the mutations which was present in patients with aplastic anemia. As you could see, number of patients do carry mutations with at time point 0, time point 6, and also time point 24. in this 24 gene panel, which we used during this study as well. And interestingly as well, as indicated before, the frequency of mutations goes up over a time period. So this is 0 month baseline, 6 months, 24 months, arm A and arm B, with increased frequency of mutations, predominantly in the IST cohort rather than in the L-Trombopac cohort, but not statistically significant. And this is from the NIH paper showing these clones can be fluctuant over a period of many, many years. And as I have indicated before, most of these mutations, nearly half of these mutations, are very small VAFs with less than 1% VAF as well. And some of these mutations go up, some go down, and some stay stable. So I think what we are seeing now is what the treatment landscape for acquired severe aplastic anemia is as indicated. This is taken from the recent updated BCSH guidelines, looking at age as a cutoff and also other options, including upfront transplant options in the context of children as well. But is L-Trombopac the only TPO mimetic? Not really. The South Korean and the Japanese investigators have shown recently the utility of romiplostin as well. But a point of caution is obviously it's not approved, but the doses used are quite high compared to ITP. So they have to use dose up to 10 microgram per kilogram or sometimes up to 20 microgram per kilogram as well. And this drug is also quite promising, which is Evertrombopac, which has been approved for ITP, but does not have any food interactions and less abnormalities on the liver dysfunction. So what happens to a patient? So this patient now achieves the partial remission to ATG and cyclosporin. He's transfusion independent with platelets of around 68 and hemoglobin of around 90. LDH remains well. He remains very well, remains transfusion independent, good quality of life, on therapeutic levels of cyclosporin. But unfortunately, a repeat bone marrow done a year after his ATG cyclosporin indicates that he has developed monosomy 7. So this is looking at his clonal evolution. These are the granulocytes and the monocyte clones in this patient. And as you could see, the LDH was not that high. It was, although the clone size was around 50 to 60%, the LDH was around 1.5 times the upper limit of normal. So if you can start voting for this question as well, hopefully I won't bore you much. There are only one more question. So how would you manage this patient? So now he's developed monosomy 7 in the context of a non-severe AA treated with ATG. Would you go for bone marrow transplantation? Would you go for a second cycle of horse or rabbit ATG? Would you give him anti-complement therapy or monitor or stop cyclosporin? So if we can start voting, I think we'll take the answers now as well because of want of time. So this patient, if you could see the poll results, that would be great. So yeah, quite rightly, transplantation was the option, but this gentleman at that time wanted to be closely monitored because he did not want a transplant at that stage, and that is what we did, although we would have been keen to offer transplant at that stage. So we know what are the events following immunosuppressive therapy in aplastic anemia. We all know that cyclosporin dependency, but we all know that there are a number of these clonal events or PNH, cytogenetic abnormalities and mutations, and also potential of development of number of other malignancies. And I would say transformation, because we tend to use this word interchangeably, because clonal evolution doesn't literally mean morphological transformation to MDS and AML. So what I would say is transformation to MDS and AML is seen around 15% of cases at a later time point at 10 years, while somatic mutations could be present in 40 to 50 or even up to 70% of cases, as you saw from some of the preliminary raised data. So, and we all know monosomy 7 can happen in a number of different contexts as well, right from the number of newer syndromes, but also in the context of myeloid neoplasia, and also some of the recently described SAMD9 and SAMD9L syndromes. And some of these abnormalities can be transient as well. And this is elegant work from NIH showing that sometimes some telomere loss precedes the somatic mutations preceding the onset of monosomy 7. But there is always this question about L-thrombopag and its potential of cytogenetic evolution in the refractory relapse setting. But if you look in the context of upfront L-thrombopag along with immunosuppressive therapy, the 2-year data showed that the clonal evolution rate was 8 years. The NIH has updated their recent cohort of around 180 odd patients, indicating that the clonal evolution rate as shown there, but the high risk clonal evolution, i.e. chromosome 7 abnormalities being only present in 5.7, while the standard clonal evolution to other abnormalities like 13q up to 4 years of around 15%. And this is also interesting because the relapse rate is around 40%, and the relapse happens at 3 different time points. 1 at the time of stopping L-thrombopag, 2 at 6 months, 2 at the time of reducing the dose of cyclosporin, 3 at the time of stopping cyclosporin, and thankfully most of these relapses have been able to be treated with reinitiation of the regimens. So what happens to our patients? So interestingly, he continues to remain reasonably well and transfusion independent despite not going for a transplant. He gets a bit anemic, and also his creatinine starts to go up. He's still on cyclosporin. The question is whether this is a multifactorial reason for all these complications, because he's getting dehydrated, he's had a contrast, and he's been investigated by the gastroenterology team for a possible Crohn's disease. I think what I'll do is I'll skip the next question, but what happens is his PNH clone is also expands out to 70% and around 40% in the red cells. So we'll skip the next polling question, Miguel. But so this is multifactorial reason why he gets it. But it's also important, if you look at his graph now, his PNH clone has started to expand out like what we saw before. But interestingly, now his LDH has crept up to around 4 times the upper limit of normal, and his red cell clone is also going up. So he's now got evolution into a hemolytic and symptomatic hemolysis due to his PNH. And let's see what happens to his monosomy 7, because his monosomy 7 also disappears now. So there is a dominance of the PNH clone over the monosomy 7, and he's been initiated on eculizumab with improvement of his creatinine, hemoglobin improvement, and staying off cyclosporin. So we all know in the context of PNH, which is due to a somatic PIGA mutation in the hematopoietic stem cells, there is lack of complement regulatory molecules, and complement is an innate system which is always active. And in the context of PNH, it leads on to hemolysis of these red cells which do not have the complement regulatory molecules and lead to a number of complications. And we all know terminal complement inhibition with eculizumab has shown a significant benefit in preventing the complications, reducing the LDH, as you could see in these number of trials between placebo and eculizumab, and also in the open label trials, and patients getting benefit from the complications and the quality of life associated with the PNH as well. And the efficacy of eculizumab has been shown in a number of clinical trials with improvement of hemolysis, prevention of thrombosis, reduction in the need for transfusions, and improvement in quality of life, and also renal complications. But there are a few issues, because some patients do get what we call it as breakthrough hemolysis during the last few days of eculizumab, and some patients need a higher dose of eculizumab. And also this phenomenon called C3D mediated extravascular hemolysis, because eculizumab binds to C5 and other than in patients with mutations. But the proximal loop or amplification loop is still intact, which leads to deposition of C3d degraded products on the red cells, which is picked up by flow cytometry, but these cells needs to be taken up by the endothelial system, reticuloendothelial system, leads on to extravascular hemolysis and persistence of anemia, which is why the landscape of PNH treatment is now totally different, with number of novel agents in clinical trials and a couple of them approved as well, including the long-acting C5 inhibitor, ravulizumab, and in US, the approval of pegcetacoplan, which is a C3 blocker. But interesting is the upcoming factor D and factor B inhibitors, which are oral compounds with good tolerability, bioavailability, and if the efficacy and the long-term safety is good, that will be a big game changer as well. So there has been a number of developments in this phase. So this gentleman, unfortunately, stays stable for a period of 2 years, but then becomes transfusion dependent, progressive cytopenia, and now he's progressing to monosomy 7. And fascinatingly, not for him, obviously, you could see that his PNH clone starts to decline, which does not happen when you're on eculizumab treatment. But if you look at his monosomy 7, his LDH improves. But if you look at his monosomy 7 clone, it was negative for a number of time points over that time period, starts to creep up, and unfortunately developed progressive MDS and monosomy 7 and had to be transplanted. So we all know the definitions of non-severe and moderate aplastic anemia, because where it does not fit into the criteria of severe or very severe. But the question is, what proportion do have non-severe disease? Is it an early phase of severe AA, or is this a distinct entity? And the other questions are, do patients with moderate aplastic anemia or non-severe aplastic anemia have a constitutional bone marrow failure? Because most often constitutional or idiopathic or inherited bone marrow failures present with subtle cytopenias. They're usually not trilineage or subtle dysplastic changes as well, because this is important to identify and delineate for a number of reasons, as was alluded to in the fantastic session last evening. So this list of familial AA MDS predisposition is going up and up as well. That's why I think it's fascinating when Dr. Lucy Godley explained that the somatic panel is static, but the acquired panel, inherited panels, needs to keep improving and improving as well, not only pick up new genes, but also to make sure that we do not miss large deletions and intronic variants as well. And there are a number of new genes which has come up, and this is a fairly recent paper from in the Jitokal's group looking at these familial MDS AML. And this is still an uncharted territory, that around 30 to 40% of patients still don't have an underlying genetic reason for their AML MDS, or we are not able to find out what is the reason for their likely inherited predisposition. And usually, because this has had a slightly more pediatric, that's why you had a few of those, but it's usually DDX and also sometimes CHEK2 as well. And we should not forget about the immune dysregulatory problems as well, as they can also cause hematological diseases, including bone marrow failure, and some of them are illustrated on the column on the right for me. And we tend to use a panel for these patients in King's, where I practice, where we look at bone marrow failure panel or neutropenia, thrombocytopenia, DBA, and lymphedema predominantly because of GATA2 and the Emberger syndrome association. And this is also a recent work, apologies, the reference has been hidden, from Daria Babishev's lab, looking at ability to predict whether a patient has got immune mediated, i.e. idiopathic, or an inherited bone marrow failure, using 6-PLOH, PNH clone, and T cell rearrangement. And they concluded that in the context of a presence of a PNH or an acquired 6-PLOH, the specificity or the positive predictive value saying that this patient has got immune-mediated is higher. Though we all anecdotally have seen patients with inherited bone marrow failures having PNH clone, and I've not seen 6-PLOH in inherited bone marrow failures, but we've seen PNH clones. But the major question, and relevant to the audience in an MDS symposium, is what proportion of these non-severe AAs are hypoplastic MDS? Yeah, because we know the definition of hypoplastic MDS is as indicated in this slide, but we know that WHO does not recognize this as a nosological entity, and we know that the clonal signature of MDS, AA, and aging can be different depending upon the proportion of the mutations as well. And the hypoplastic MDS guidelines definition is based nearly 13 years back, and that was based upon a handful of patients. So what we set out in this study, which was published in Leukemia a couple of years, is to identify how we can separate out a hypoplastic MDS from an immune-mediated aplastic anemia and also an inherited bone marrow failure, based upon somatic mutations, cytogenetic abnormalities, multiplicity of mutations, and also the distribution of VAF as well. And that was able to show and segregate patients who had a low score based upon genomic and histological findings, despite them being called as MDS. If they had a low histological and genetic score, they behaved more like an aplastic anemia, while a patient who had a multiple mutations or other histological finding behaved like a standard normocellular or a hypercellular MDS, both in AML progression and overall survival. So essentially to show that we are able to identify these distinct groups, segregating immune-mediated from malignant bone marrow failure due to myelodysplastic syndrome as well. And this was sort of said about 5 years back, pragmatically, from looking at the etiology of bone marrow failure. If you have DEL13 and UPD and PIGA, would that be immune-mediated? But if you have other abnormalities, would it more behave like an MDS? But medicine is always fascinating. They never fall into boxes. There will be a number of patients who fall into this middle territory as well. So again, there has been good data from Cleveland Clinic, from Jarek Meszczyński, looking at what happens to this moderate aplastic anemia, and a large number of patients of around 85 compared to severe and very severe aplastic anemia patients, and showing the clinical course of these patients, and quite a lot of patients remaining, 2/3 remaining as moderate aplastic anemia, and also their therapeutic modalities over a period of time, nearly 50% of them not requiring any treatment, while the rest of them cycling through a number of lines of therapy, but predominantly either as a single agent cyclosporin or androgen, very rarely having ATG and cyclosporin. So, and L-Trombopag has been used based on this NIH study in moderate aplastic anemia, with around 50% of patients achieving a response. And as I said before, at 1/10 of the patients do have an underlying constitutional bone marrow failure, and most patients do need a significantly long period of L-Trombopag, but low incidence of cytogenetic and genetic abnormalities seen in this moderate aplastic anemia group. And we talked about the romiplostin, so I'll skip through that slide as well. And it's important to look at transplant as well in the context of aplastic anemia, because with the use of a regimen using alemtuzumab, which is predominantly used in UK, but also some centers in US, Canada, and also in some places in Italy, the outcome for this kind of transplant is extremely good, as shown in the recent update with GVHD-free, relapse-free survival for patients with lower age and lower HCTCI approaching up to 90-95%. And even for patients with poorer HCTCI more than 3 and older age, it is not bad with an overall survival of around 76%. And age score was around 45. So we can think of difference between an ATG cyclosporin L thrombopag to an FCC transplant, because potential curative option, low TRM, low risk of GVHD, while with ATG cyclosporin and L thrombopag, there has been significant improvements, but unfortunately relapse and late clonal changes are something to look out for. In the last 5 minutes, what I'll do is I'll try to finish off with some of the rarer entities. So this was a gentleman who presented with a significant degree of anemia and reticulocytopenia with a normal blood film and every other investigation being normal. His bone marrow did not have any erythroid precursors, and he had some reactive lymphoid aggregates, and CT showed small volume lymph nodes. He had a very good long-standing history of autoimmune hepatitis, mouth and genital ulcers, and rheumatoid arthritis as well. And he also had some other constitutional findings, including microcephaly, high arch palate, and hyperpigmented patches. So we thought this gentleman is more likely an acquired pure red cell aplasia because of his significant immune-related changes, but we were concerned with his other findings, and we did a bone marrow failure panel, and we were able to find a class 4 variant in heterozygote in RPL5, which affects splicing. So the question is, does this patient have an acquired PRCA or a Diamond-Blackfan anemia? But interestingly, we gave him a therapeutic trial of cyclosporin, and he remains till date to be transfusion independent. So some of the things which look like inherited might respond to agents which we use for acquired conditions, and vice versa as well. So we know that pure red cell aplasia is not a rare entity, but it can happen in a number of different causes as well. And one of the things we are focusing on is the PRC associated with MDS, because they're extremely recalcitrant to treatment. And the anti-EPO antibody phenomenon, we only got one case, but the rest of them are predominantly thymoma, immune-mediated, and important to make sure that there is no del(5q). The reason for this is because even in patients with del(5q), you can be caught out that the erythroid activity is significantly limited and inducing in about less than 20% erythroid activity as well. And this is a fantastic article from Kamala Guri and also Jarek Maciejewski looking at different forms of the PRCA and how to manage them as well. And one of the closely linked entity is this, it's this TLGL, because we feel that in around 30 to 40% of pure, you could see this entity of TLGL, which is associated with JAK-STAT constitutional activation and also to STAT3. And quite a lot of patients with logical condition like an autoimmune disease like rheumatoid arthritis, they respond very well to methotrexate, but cyclosporin and cyclophosphamide are quite effective as well. So it's important to make sure that you have to rule out other ribosomopathies which are indicated on there. And we do this genetic panel to look at these number of these inherited predisposition for either marrow failure, neutropenia, thrombocytopenia, or rare anemia. Lastly, I would want to finish with this case. She was a lady I saw a couple of years back now, or years back. She was from Pakistan. She had a new macrocytic anemia and was transfusion dependent with moderate neutropenia, but was hypoplastic with reduced or absent erythropoiesis and had T lymphocytosis as well, and had quite a lot of autoimmune features as well, with at least with the serology. So to rule out, investigate for DBA, we do a quick red cell ADA levels, but we also do the genetic screening. So we thought this was a likely pure red cell aplasia with T large granular lymphocytes. But when we go into the history, the first cousins, there is an abnormal blood count in her mouth, and we look at the inherited bone marrow failure panel, and she's got an apparent homozygous CECR1 or the ADA2 abnormality. leading on to absent ADA2 levels. And people shouldn't be confused with this ADA2 with the red cell ADA, which is for Diamond-Blackfan anemia, while ADA2 is for the DADA2 deficiency. So this is more likely an overall DADA2 deficiency. But interestingly, we started her on cyclosporin, and she remains remarkably well and transfusion independent. So what I'm trying to show here is, although there might be this is well described that the DADA2 has got significant inflammatory issues, but again indicating that some of the agents which we use for acquired conditions can induce responses in patients with constitutional marrow failure syndromes as well. So I'll skip that. So just to conclude, I'm going to put it that AA is probably a purely autoimmune disease, with the possible exception of inherited bone marrow failure syndromes, but with the caveats which I said. And most patients can have age-related clonal hemopoiesis, or they could have a recovery clonal or oligoclonal hemopoiesis, but there is still a risk of transformation, malignant transformation to MDS and AML. But some patients recover normal hemopoiesis without any clones identified. Well, PNH is a monogenic disease, and MDS, as we know, is a clonal disease, but there is a significant coexisting immune dysregulation seen with autoimmunity, but recently description of autoinflammation as well, like seen in the Sweet syndrome and the Vexus syndrome. And personally, I think hyperplastic MDS deserves a separate, distinct entity in the classification so that people can differentiate as well. So with that, I've just left with thanking some of the people, a couple of my mentors, Professor Makti and Marsh, and my colleagues, quite a lot of funding agencies and people who have helped in the laboratory, and more importantly, recently with the EBMT group, fantastic colleagues, Antonio Regis and Carlo, as part of the RACE team, and also the National PNH Service, which I lead one of the centers in Keynes. So thank you so much for listening. Happy to take questions in the next 10-15 minutes, and we'll try to keep it interactive. So do please keep coming with questions. I'll see if there are any questions coming up on there. So keep asking if you have any questions. So you can ask questions either in the chat, or you can raise your hand, and we will make sure you're unmuted, and happy to answer questions as well. Obviously, it's a large topic to cover, but hopefully you got something out from this. And obviously, it's always a very difficult thing when you do this virtually, because I'm sure you got loads of questions, but it's always difficult on a virtual platform. But if you do want to either put it on the chat or raise your hands, and Miguel will let you into the platform so that we can have a chat. If not, unfortunately, you have to hear the monotone of my voice, I think so, which is not good for a long time. So I can't see any questions yet. So either I've been very clear or the other way around, I think so. So I don't know whether there is anything which you want to particularly address, but as I said, it's a sort of dynamic changes with these patients, because it's not both AA, PNH, and MDS, or all three of them, and also including TLGL and pure red cell aplasia. They are not necessarily diseases which are static. So they are dynamic diseases. So I've got a couple of questions, which is fantastic. So do we necessarily need hypocellular BM in MDS in order to indicate IST? So that's a very good question, because most of the data for use of IST in MDS is very old data. And there are a couple of papers which were published in the early 2000s, and there was a recent update, which either was in Blood Advances or somewhere where there was a large group of patients put together who were treated with ATG, cyclosporin, or cyclosporin alone. In that, hypocellularity did come up as a factor predicting response, although age is a factor as well. And historically, we always used to say, even in MDS, if they have a PNH clone or if they had a HLA-DR15 positivity, they do respond to immunosuppression in the context of MDS. But I think hypocellularity and age were the two major predictive factors for response to immunosuppressive therapy in MDS. Although, to be frank, personally, I've not used ATG for an hypoplastic MDS for the last 5 to 8 years at all, because I know it is a good treatment, but people rarely use it nowadays, and will probably use a single agent cyclosporin to see if they have a response. And if they don't have a response, then they might be taken to an allogeneic transplantation. So hope that answers that question. So the second question is, I have a patient with a history of moderate AA 20 years ago, never needed treatment, now has 4% blasts, no cytoabnormalities, MIPL on NGS with a VAF of 36%, no PNH, 4% blasts on the bone marrow biopsy, normal hemoglobin and platelets, but ANC is 0.2, mild infections occasionally. What do you suggest? I think this is a difficult one, because if you just look at it from a clinical perspective with a patient remaining well, other than just possibly having severe neutropenia with mild infections, if you keep the NGS to one side, we just need to ascertain why this patient has got severe neutropenia. So like what I said before, I will definitely look for any evidence of TLGLs. So I'll do a peripheral blood flow to look for TLGLs. I will do a STAT3 mutation if possible, if it's available. I'll also do TCR clonality, because the degree of neutropenia is quite disproportionate to the rest of the counts. So I want to make sure that it is done to ascertain whether there is a TLGL component, because despite the presence of a borderline blast of 4%, if there is a TLGL component, then there is a potential of thinking, if a treatment is needed, giving her steroids and cyclosporin to see if there is a response in it. The second thing is, this patient, because of the long-standing nature of moderate AA, there is a potential risk that this could be an underlying occult inherited bone marrow failure. Although we are not told to make decisions that a MIPL VAF of 36 could be constitutional or acquired, it is important to make sure that you do a proper germline panel to find out if there is any other abnormalities of inherited bone marrow failure genes, to ascertain if you're not missing any of those. And secondly, if you rule that out, then you just need to extremely closely monitor, because I think you and the patient will be totally happy if she or he goes for another 20 years with similar things. I don't know how old this patient is, but it is an important thing, because you can continue to monitor this very carefully and closely, so that you can keep an eye on it rather than intervening. But I would do those things in the interim to see what is the real reason this patient has got a moderate AA. Is it immune? Is it inherited? Is there an MDS component? Yeah. That's good. So I think I've got another question come through as well. So this is from Dr. Soni Kumu. Does presence of a small PNH clone in the setting of pancytopenia and hypocellular marrow confirms acquired AA in a young patient? I would say, if I give you a very short answer to that, I will say 100% yes. Because PNH clone, as I showed in the recent data from the group from Daria Babishek, where the positive predictive value of this of diagnosis of an immune-mediated aplastic anemia is extremely high if either they see a PNH clone or a 6p loss of heterozygosity. So I think it is important that is looked at, but most likely this is more likely an acquired AA in the right context, or at least this is an immune-mediated bone marrow dysfunction rather than inherited or other things. And just a small side note is rarely we have seen PNH clones in inherited bone marrow failures as well. So that's something you need to be careful about. Okay, so if there is any final last-minute questions, I'm happy to answer. But if not, I think thank you so much for attending this session. And thank you for the technical support team as well. And thank you for all the organizers as well for making this virtual and interactive as well. So hope you have a fantastic rest of the conference. And I think we'll have 4 minutes back to you. So at least you can relax if you're going into the next session. Thank you so much and have a good day, good night, or whatever, wherever time zone you're in. Thank you.